nice scan machine, but whatever your scan machine, turn it on, start it every day, and it doesn't get switched off till you're finished. We're scanning almost every patient that comes in. We've got somebody come with a carpal tunnel. Clinically, it's a clear carpal tunnel, hasn't had nerve studies, long waiting list to get it fixed, and so she's looking for some relief, so we're going to do a steroid injection. Some people are fans of doing this, some people are not. In the past, I've found often get 2 or 3 months relief from a steroid injection. Nearly always comes back, sometimes doesn't come back, but occasionally you'll cure somebody, especially if it's mild. But often you can give people significant relief so they can just get on with life. For this person, they really can't do anything with this hand, it's just so sore. Can't do their cooking, can't do even some of their normal ADLs. So we've done a little bit of prep. We're ready. I normally do a kind of no-touch technique, just disposable gloves. You often see, I have seen orthopedic surgeons do these just with a bit of a wipe from an alcohol wipe and pop the needle in. I tend to use a bit of betadine. So let's just prepare the skin quickly. We've had a good chat to the patient to explain, that it's okay to feel relaxed about having this done. It's a very small procedure. It's so much better under ultrasound guidance, so much more accurate, and you'll see as we look on the screen how easy it would be for you to put the solution in the wrong place. Can you put it in the wrong place? Well, maybe the solution diffuses through the tunnel and works, but I find it works better if you donut the nerve. So you find the nerve, donut the nerve with some local with your steroid. I use Depomedrol. You can use Kinecort, but I think Depomedrol is better. And yeah, I find that gives good results. So let's see how we go. Let's have a look. So first of all, put lots of sterile gel. Okay, heaps of gel. And then we're just going to have a look on the screen. That's right, so I'm just looking in transverse. See how much gel we've got. And that way, see, you get a nice picture if you don't touch the skin. If you touch the skin, you watch what happens. See that you can see this blood vessel, for example. If you touch the skin, even lightly, you might lose the blood vessel, like that. And then you can accidentally put your needle through it on the way to the nerve. So we just want a really light touch. We want to identify the area, of course. So we've got to find the nerve. So if you look back on the skin, we know the nerve sort of runs down the middle of the forearm there. I usually go back down the arm and find the nerve, and I'll just show you on the screen. So a nerve looks, normally the median nerve in the forearm is a triangle. And then I'm just kind of coming down, I'm looking transverse, right? You've got your skin, muscle, that's the nerve. And I'm just moving the probe down towards the wrist. And you would see the nerve kind of come up to the skin. There it is there. Yeah, it's sort of up at the skin. In fact, that's the whole nerve there. It's sort of like, see how it sort of almost tried to divide a little bit there. So that's our nerve. Asked her to wriggle her fingers. So everything moves, all the muscles move, but the nerve doesn't. And on some, thank you, yeah. Sometimes the nerve will look a bit like a honeycomb. Can get caught out with this structure here. I think this is probably palmaris longus, which looks a bit like the nerve. But if I follow it back up the forearm, it stays very superficial. So that's just palmaris longus. Whereas if we go back, there's the nerve. Yeah, there's the nerve there. Sometimes you'll see the nerve squished or crimped a little bit as it tries to go through the tunnel. If I keep going into the hand, it sort of dives down and we lose it. So we just want to get it nice and superficial there. That's good. So we're going to come in an in-plane direction. We want the nerve in the middle of the screen. Wrist crease. So that's the nerve, that dark area there. All right, so we're just going to do, you'll just feel a little sting in the skin, okay? Just on the side. Can you maybe explain that, Kalisa? Yeah.
Diam-diam nek, disuruh diam-diam. Kamu tak bergerak.
Oh, bergerak.
Little sting, sorry. Let's see, so we're watching the screen. Little sting, sorry. Bagus. We'll see whether we can find the needle there. So we already see, you can see it on the left hand side, already quite deep. See, it's way down there. See there? So we come up a little bit, angle it a bit up. We just come in beside the nerve. We don't want to hit the nerve, we just want to be beside it. Put a little fluid in. Here we go. Yeah. Just move a wee bit closer. A bit more fluid. There we go. That's right beside the nerve. Might even just put a bit underneath it there. Is she feeling okay, Kalisa?
Okay nek? Nenek okay?
Yeah, so it's pretty comfortable now. So let's just go in underneath the nerve there. There we go. So sort of half donated it. And you get a sense that, you know, if you were doing this under, you know, just with a, if you were just doing this with a anatomical technique, it'd be hard to get quite that level of accuracy. It's finished. So, yeah, it's nice to do that, and we can give this person, you know, a bit of comfort and a bit more time before she's waiting for her surgery. Also, some places, especially this place where I'm working right now, if you do because often the diagnosis of a carpal tunnel is a little bit uncertain. If you've done a steroid shot and you've got a good benefit for a couple of months, that adds to the diagnostic certainty, and people will often get processed a bit faster, and they don't necessarily need to have the nerve conduction studies that you might have had to do. Thanks very much for watching.